thank you to the panelists, three very excellent presentations. And now we are going to open the discussion to the audience with questions. We'd like to remind you, please, to come to the microphone, identify yourself, and tell us who you're directing the question to. So questions, please.
Hi, I'm Matt Quinn from the FCC. One of the things that we've seen in the Affordable Care Act is a focus on accountable care organizations and patient-centered medical homes. In the case of patient-centered medical homes, a couple of the key tenets are that it's primary care led. Second, that it's around the patient's needs rather than the needs of the healthcare system. And third, that it's connected to community models, so not just physicians, but others outside of the healthcare system. One of the other pieces is that mental health is incorporated in this. How much have we seen that hearing health and vision health and others have been incorporated in that?
Well, I'll speak a little bit. Is this on? I'll speak a little bit to that. I think we pushed for, or at least a number of us, I think, wrote to see if it would be one of the essential services, and it didn't make that package, although you can work with it at a state level. But one of the models that might be helpful in terms of thinking about it is the PACE, the Program for All-Inclusive Care of the Elderly. That's been started with ONLOC in San Francisco, but it's an at-risk program. In other words, it's always been based on getting a lump sum to take care of older adults. And these are very frail older adults as well. And they've always come at it from a patient-oriented perspective, which means that they can use that funds whatever they want in terms of meeting the needs of the patient. Right. So they are much more likely in some ways to provide hearing aids if they feel that it's a patient need, rather than some of the other organizations. So I do think that it does matter. I do think that the education of the practitioners to really understand the needs. In other words, I think it would make a difference for the persons who get screened, because if a practitioner, earlier I think it was mentioned, like hypertension, for instance, if someone comes in and has their blood pressure taken and they have high blood pressure, their practitioner pays attention to that. And if they repeatedly do, they'll say, you know, it looks like you have high blood pressure, you should be on a special diet or you should be taking medications. They know it's a health need. So I think that, again, if we somehow build it in, it becomes something that's much, much more acceptable, and then, you know, begin to monitor outcomes. But I have not seen it as a focus, unfortunately.
I wonder if any of the recognized CMS ACOs have incorporated hearing loss management and prevention. I mean, I don't.
Medicare Advantage, some of the Medicare Advantage programs do cover hearing, or have. It used to, yeah. See, with the change in, yeah, and we've talked some. I'm trying to think about, you know, it even never fell into the Welcome to Medicare exam, which, you know, or the risk factor exam that's supposed to be done every year. So and unfortunately, because right now in Medicare it's a statutory exclusionary cause, there has to be change in the legislation to make a difference, you know, to change Medicare legislation. And although it's been tried, many people have, beginning back in 1977 with Claude Pepper, he introduced a bill to change Medicare to cover these services. It never goes anywhere because there isn't the push.
Great, thank you.
Just to follow up on this question related to the Affordable Care Act, because coverage under the Act is really designed to mimic the commercial healthcare system, we're not seeing much coverage of hearing aids. And if the state has a statute that requires coverage for children, then it's being covered. But we're not seeing very much adult coverage of hearing aids. Cochlear implants, because they're typically covered by commercial plans, are being covered under the Affordable Care Act. So that's just to answer your question.
So one topic I wanted to just sort of raise, which I think is relatively provocative, I thought this would be the perfect panel to get feedback on it, is, and Nikolai sort of alluded to this in the past, that, you know, people have different levels of needs of care. So some people need sort of everything. Some people with let's say, a very mild hearing impairment just need something very, very quick. So about 10 years ago, I mean, so right now hearing aids are all regulated by the FDA, and by virtue of that, because it's a medical device, they need to be dispensed typically by a audiologist or a hearing aid dispenser. And 10 years ago, I think there was a citizen's position at FDA to develop a new class of hearing aids, essentially an over-the-counter hearing aid that would be open immediately to consumers. And I think that's idea, and that gets the idea of personal sound amplification products have sort of come now too. But I sort of want to get from the audiologist opinion, the industry perspective, as more of a policy perspective, thoughts on the role of a separate class for over-the-counter hearing aids with a maximum prescribed output. So in terms of safety considerations, hopefully that'll be alleviated. But just to get overall thoughts on whether this might be another time now to re-entertain this issue of over-the-counter hearing aid class.
And who would like to answer that? Or do you have a?
I think there'll be a different perspective from maybe all three, actually, ideally.
Yeah, I don't have a problem talking to this. I mean, I think, as we've heard over and over again today, there is clear evidence that you need to have some sort of assessment made of your problem. In the fact that you know that you have a hearing impairment, I think most people can figure that out. But the step from there to know what to do about it, I still think merits a bit more investigation than just buying a product and seeing if it works. And the other part about that is that, I mean, those who do not have hearing aids, as I also said, are typically also people with a smaller problem. People with a smaller problem are not the least difficult customers to deal with because they only need the product in certain proportions of their life, and the rest of the time they are not really happy with it. And so the less accurate fittings you do for that group, the higher the likelihood, in my thinking, is that they will not be happy with the product in general. And therefore, I'm not so convinced that it's sort of like one class and then another high-price class. I would rather like to see a continuum between the two, where you get maybe a smaller service package for a need that is not so complicated. Because I mean, this type of amplifiers actually doesn't really exist in Europe in any reasonable extent. They do bring them about every now and then, but in most countries it never really flies. And one of the reasons is that you can actually get a decent solution in other ways that most people actually seem to be more happy with. So I'm personally not so convinced about the benefit of it, and it has existed for ages. I mean, it has never gone anywhere, if you want to. I'm not paranoid about this because it has been there all along and it has never succeeded. And I think the explanation is that the lack of the proper assessment and the process of getting people acquainted with it and understanding what it can do and what it cannot do.
I agree with that. As I tried to show in my talk, if hearing loss was only due to audibility issues, then that would resolve the problems. But you have the distortion component, and then with aging, the cognitive resource issue and cognitive factors. So utilizing a device that provides amplification without understanding limitations, without learning about strategies, appropriate use, and is not, I don't think, going to resolve the problems. And I think you do run into the issue of someone trying something, it not satisfying them or having their needs and then giving up on the whole process. I don't think everybody who comes in to see us needs a hearing aid either. I mean, you can give, I had sort of a classic story that I tell my students. I had a woman come in and her only communication need, she had a mild hearing loss, and her communication need was when she was riding in the car with her sister, because she also depended a lot on visual cues. So I gave her a hardwired pocket talker. That was fine for her for a year or two. And then because I didn't push hearing aids, she was ready 2 years later to come back and try them. But if you don't do that pre-assessment, if you don't consider all of your options when the person comes in, then I think we're doing a disservice. And I think that there's just so much misinformation out there and misunderstanding of what a hearing loss really is like and what it does to the signal and speech, it's not a simple answer and it's not a simple solution. Otherwise, the engineers would have solved it years ago and we wouldn't be here today. So that's my 2 cents.
I guess we're pretty much on the same page, but I would be concerned for the same reasons in terms of how do you get the right people to be the people who are purchasing it, the people who are really savvy about it and so forth. I think if it was, we're beginning to design, and we already see this because the PSP, with the personal amplifying sound systems, are not regulated. And so they are available over online. And I know some of them are actually getting better. And there are some new products that actually can be self-regulated, in other words, self-programmed, if you will, right? So that it's possible down the line that if you have online self-hearing assessments, if you will, with people who are really savvy, who can sort of see what their audiogram might look like or get at least an idea, and are really technologically adept at doing that. But I think for a lot of, especially really elderly individuals, some of those processes would be really difficult. And unless they have the classes and the other programs that would really assist them, they won't be getting the service. And I do worry that they would try something like you mentioned and say, oh, this doesn't work, because that's, and then just not go and actually get something. We don't have good data on that, though.
Yeah.
But
Need to study.
that's an issue.
I think the main reason I bring up just one last quick point is I think purely from the perspective of public health now. Namely, if we think, all of us probably agree hearing is important, right? But if 2/3 of every older adult has a hearing impairment, the current models of care won't be able to sustain it. That's a problem. So I guess what I always actively think about is what do we do if we think hearing accessibility and hearing access is a good thing? What can we actually do to achieve it, though, right? And I'm honestly just quite not sure, right, at this point.
But I think if it was embedded in a really good consumer education program where they understood the limitations and knew, that if they had problems that this was a first step or something. So there was a lot of work, I think, that would need to surround that somehow.
I'll let Kathy go, but that's that whole issue, too, of bundling and unbundling so that people understand what's the device cost versus the other services. And that perhaps, if you work with people in the Hearing Loss Association of America, et cetera, not all of the non-technical intervention has to be done by an audiologist, too. You can train community workers. There are other people that can provide some of those options. So if you think about changing the model of how you're doing things and to involve other organizations and communities and people with hearing loss themselves, I think we can have some solutions that could be cost effective.
Okay, well, I just will make a small footnote that Canada is a different country. We're a little different sometimes too. So in the spirit of being a little different, I really like this juxtaposition of the marketing view versus the healthcare policy view. And I think we need to have more discussions like that. And I have questions that I would, like to explore. I don't think you have the answers, but it comes to my mind that, maybe some of those differences in countries have to do not with aging, but say with industrial noise exposures and people who have gotten their hearing aids because they were in hearing conservation programs in industry, and because hearing aids were provided through workers' compensation for occupational hearing loss. That there are in some countries going to be, including the US, large numbers of people who have entered the hearing care system because they have military exposures. And so we kind of, I think, have to separate out the population according to the etiology, and we might have a little different picture if we focus strictly on the presbycusic population. I also, GDP is kind of interesting, but there's a large literature on the social determinants of health more broadly, which would say that it's the distribution of wealth in the country which is predictive of health outcomes as opposed to the average. And that is another interesting thing we could explore and gets to this matter of the privileged and the underprivileged. But my kind of real burning question for you is, what is industry's commitment to helping with this agenda? And we put a lot of emphasis, we try to be dutiful in terms of using evidence base to guide practice and policy. And I'm going to share, I know there's a lot of differences amongst health practitioners and amongst our industry partners, but I'll share a story which I find rather horrifying. So a few months ago, I was in the audiology clinic at Baycrest, big geriatric hospital. A patient comes in to the audiologist to get a hearing aid, clutching a local newspaper in which there is a full-page ad with very tiny print that says that it's a paid article, but it looks like, it's an ad, but it looks like a news item. And it says that researchers in the hearing aid industry have proven that if you get a hearing aid, you will not get dementia.
Oh.
And the person has come to the clinic with this expectation. So what are your ethics, and what are you doing to make sure that people don't go crazy without evidence trying to create sales out of our good intentions? So a very provocative question, and you're the person who can make it right.
In the hot seat, yeah, thank you.
He's leaving the U.S. tomorrow.
Yeah, I will change my flight to an early one.
The ad was by one of your related companies, by the way.
Yeah, there's no doubt that there are inappropriate advertising going on. I wouldn't deny that. I have the luxury of not being involved in that particular part of the trade. And I don't think it's fair. I will though say that one of the few things that have actually persuaded people to consider to get a hearing aid is actually this threat of dementia and cognitive decline. I mean, we have tried with happy grandchildren on your lap for about 45 years with relatively lackluster results. And there was a Danish head doctor who went out and said, you know, for your own good sake, you should consider to have a hearing aid. And that was maybe slightly more ethical way to present it. So I think I'm not defending the way it was done. I think the idea of telling people that it may have consequences not to use hearing aids is actually an interesting thing if there is scientific evidence to do so. I just agree with you that it's maybe not appropriate to do it that way, but the idea of making people aware of this, I don't think is inappropriate.
Hi. I had a quick comment and also a question. The majority of hearing loss in the world is actually not in our countries, but in developing countries. And their populations are aging too. In the past, as incomes have grown in these places, they have been at the forefront of some innovations in terms of delivery of healthcare. For example, the use of cell phones in delivering healthcare and also tracking disease. Perhaps because they're not burdened by the systems that we have and also the entrenchment of industry and professional societies and whatnot. So I'm just wondering, in your experience, do you know of any innovations coming from these places in terms of healthcare policy related to hearing? And if not, then I think it'd be interesting to see if any occur over the next few years in terms of, I mean, which might be helpful in terms of lowering cost.
There actually are some individuals who have specifically designed hearing aids. One that is, I think, solar powered, and it's developed in the countries themselves, and other ones that are more self-programmed, if you will, and that are much more low cost. So there are individuals actually working on models that they, partly because they started to work in low-income countries and wanted to make them low cost. And I think they will we're beginning to see those coming back here and being promoted for use in this country.
My name is Alicia Spoor. I'm here with the Academy of Doctors of Audiology. I actually have a question for Nikolai. Knowing that Dr. Urban and myself are of the younger generation, and we're paying into things in the United States that we may not see, like Social Security and Medicare, as it's getting revamped, I'm curious as to the cost of what all of these devices might be. And I'm curious if maybe you can comment in the European models, how much does the society end up paying into the healthcare system where they then get free or reduced cost devices if they're fortunate to live long enough to actually benefit from them?
Not sure I have any accurate data. I mean, I can remember what the cost of the private part of the Danish system was a couple of years ago. I think it was estimated at 270 million Danish kroners, which you can translate into what, $50 million for a population of 5 million people. So it's not an insignificant amount of money. That's correct. In Denmark, it is seen as a natural thing to provide people with all sorts of services. Any hospital procedure that you can wish for is free. And it is just a different way of looking at this. We have had it for years, and it's, yeah, we think it's wonderful. But of course, it also means you have to pay high taxes. But generally speaking, I think anybody I know that has been through a major hospitalization and surgery and came home without a bill, they are pretty happy paying their taxes after that, instead of taking a mortgage in their house or whatever it takes to get things done. It's a difficult question. I mean, we are just raised with it, and it's been like that for years. I mean, it's less expensive in other countries where they pay less, clearly. It's a hard question. As I said, I think we will move towards a situation where more people will have to pay certain parts themselves, and they should be given the understanding that it is worthwhile to pay for it. They may still think it's very expensive, and there might still be some opportunities to lower the cost. I wouldn't disagree with that. I think it would be good. But we don't generally advise our customers. I mean, we just supply to the dispensing community. We don't spend much time giving them great advice about how to run their businesses in that term, on that term. So it is costly, yes. There's no doubt about it. I wouldn't try to hide that.
Jim.
Listening to this panel, and actually I probably could have asked a question of the earlier panel, but I wonder if we do this cause a disservice by lumping together mild hearing loss with moderate and severe. If we had had an entire conference on moderate and severe loss and implications and prevalence, et cetera, and a separate one on mild loss, would we have come to different conclusions, or as we're describing the dimensions of the problem, the intervention, the necessity of treatment, what does it help or hurt for us to be clearer in distinguishing? There's a prevalence of 70% of people over 85 have hearing loss, but how much of that's mild? Is mild like mild hypertension or borderline hypertension versus severe? So I'd just be interested in any thoughts on whether it helps or hurts to try to more clearly distinguish between mild and the moderate to severe population.
Yes, but not only based on the audiogram. You need to look at speech understanding abilities. And so it's not just, you can't just say every mild hearing loss is the same. There are processing issues, cognitive factors that all are integrate to determine the impact. And so it is hard to separate based on that. I certainly think when we talk about severe to profound or the more profound, and can that person benefit from acoustic amplification, we might be talking about different things. And then, well, yeah, so, but that was a good point. We have to think about different needs at different levels of impairment or handicap, so.
I think coming at it from more of a health perspective, I think one of the things that, and I don't think we have good enough data at this point to really show this, but there are some data about auditory plasticity in terms of thinking about the fact that it's kind of like a muscle. If you don't use it, it decides to do something else. And so I think that the changes that occur when you're not getting acoustic stimulation in the brain itself raises issues about whether early intervention is positive in terms of minimizing problems later. And so I think that from that standpoint, we need more data on if we do early intervention, are we making it easier for individuals to then adapt long-term to, you know, admittedly their hearing loss may continue to decline. Maybe it won't be as bad, but their speech understanding may stay better, and their ability to use various devices may be better. Because they've started early. So I think from that standpoint, even thinking from health, if you have hypertension, the goal is to treat it early so that you minimize the side effects of it long term. You don't get the microvascular, et cetera. So that just from a health standpoint, I think that it's probably good to think of it as a continuum.
Certainly, the animal research supports the, having the augmented acoustic environment, and the animal data support that.
Okay, so we'll take a question here and then there.
Okay. I'm Noreen Gibbons. I'm a clinical audiologist with High Health Innovations, and this is actually for Nicole. I'm wondering if there's an age of intervention lower in Europe than we see in the U.S. Having been at Henry Ford for many years, there was a lot of third-party coverage, and I'm convinced people started sooner as with hearing aids. And as a clinician, there's nothing more challenging than a 90-year-old coming in for the first time to learn how to use hearing aids. So intervention early for milder loss is great, but also their dexterity's better, vision's better. So does Europe have any better rates, lower rate age?
I think so. I don't have any evidence to support it, but it's clear that the success rate for very old people coming in finally to get a hearing aid after 16 years of denial, the success rate is clearly much, much less. And if you take the mature decision when you start to have complaints from other people, your family, that you are not hearing properly, that you have it assessed, and if there is a problem, you address it and get some remedy for it, you will be able to maintain your sort of ability to do stuff much more easily throughout age. And I would say, back to the question about the cost, I mean, there is another element to it, that your ability to keep your job, for instance, goes up tremendously if you take care of your hearing. I mean, we did a big study some years ago in Denmark called Unheard, where we interviewed 3,000 people between 55 and 70, I think, randomly picked, full interview and full audiometric test or a threshold test. And the interesting part there was that when you asked people, do you think that you have a hearing loss? And they said, yes, I recognize I have some issues with hearing. Do you think that your hearing loss is impacting your conditions at work? Most of them almost said, no, I don't think it matters at work. But then at a later section in the questionnaire, there were like a dozen questions about how do you feel at work with your colleagues? Do you think your boss is always on your back? And other questions like that. And in that category, they came out clearly different. Much more paranoid about everything than their peers with a better hearing capacity. So there is evidence that you should do these things for your own sake. And because it actually improves you, I mean, where I come from, you go on welfare and become a burden to society rather than an asset to society by working. I think most societies have this understanding that if you do work and make income, you pay taxes, and you are an asset to society. And therefore, your ability to keep that ability as long as possible is tightly related to you, at least for many types of work where you have to interact with other people. With that, they're quite abundant, I would say. So there is another, it's just difficult to quantify exactly what does it mean in terms of money. You can do some calculations. We've done them, and it came out with astronomical numbers, and I was not very inclined to tell them because I think they're ridiculous. But there is another part of the equation. What do you get for the money you spend in terms of keeping people in their private homes longer instead of taking them to nursing homes and all these things that is also costing society some money. So that is on the other side of the equation. Not so easy to quantify, but I truly believe that there is this other side.
Okay, is that it? Other question, one more question?
One more. Barbara
And
Lewis.
two more questions, yeah. Oh, no, she doesn't, okay.
Okay, thanks.
Go ahead.
My name is Bill Dickinson. I'm with Phonak LLC here in the U.S. But I'm going to take a second and just wear my clinical audiology hat and kind of give kudos to Kathy for throwing the flag on the advertisement. But I'm probably going to deflect that a little bit. I don't know how much that is the role and responsibility of the manufacturing community, as much as we need to start bringing in some self-regulation of our own professions. And we have ethics boards, we have self-regulatory boards, we got state licensing boards, and what we need to do is be able to throw the flag on each other when that occurs, because that probably, I don't know the ad, but it may not have, there was probably a clinic tied to that. And so I'd certainly like to see a little bit of improvement in self-regulatory behavior. A question probably for Teresa in terms of tying things back to, say, the AAA guidelines, which is kind of a minimal set of standards. And earlier this morning, I'm not sure, I apologize, I think it was Jim, who said that you can't fix what you can't measure. And I'm wondering where we are with some progress on, we've been kind of riding a one-trick pony on a pure tone audiogram for a long time in determining candidacy. While it's not the candidacy, we tend to treat it as the main gatekeeper for permission to treat. So I just wonder if there's any new things on the horizons as far as better diagnostic tests to kind of further explore this amazing nonlinear processing cochlea that has all kinds of damage and dysfunction that's going along with it, also tied to the central nervous system, that maybe we'll stop relying as much on that audiogram, which is not telling us a lot.
That would be nice. No, I mean, I think it's, even just OAEs give us more information about the system. I think it's critical to do speech and noise testing. I think that's something that should be routine in every clinic, and it's not. We started out by doing, you have to do the whole battery of tests. And I think you can measure cognition. You have some, Kathy, didn't you publish something recently about cognitive measures that we can include in audiology?
Nina Kraus did.
Was it you?
Nina Kraus did.
Nina Kraus? No, I think it was Kathy.
Hearing
The MoCA, doing the MoCA.
Well, just to, that's a whole other discussion, but I'm scared to death because now audiologists have gotten that it's important to understand cognition, and there are cognitive tests, but we don't know what to do with them in audiology practice. So I don't think it's quite ready for prime time, and that's another, practice implementation discussion that we need to have. Sorry.
I just want to add to that. What we know from the literature is that the pure tone audiogram is not the predictor for hearing aid uptake. So you have to look at all the predictors of hearing aid uptake, and the audiogram is probably the least significant. So at the input level, we have to use the measures that are predictive of uptake and successful outcomes. So, and I think, I can't talk about that, but there's plenty of information on that. And just to use the audiogram, that was 40 years ago when Jim had hair and I had no gray hairs.
I do want to comment, though, that if you don't have access to the acoustic speech signal, you've got nothing to start with. So, you do still need to know what your access is, because that's one step, but that's not the be-all and end-all, at least in my humble opinion. Bob may have comments on that. Diagnostics and, no? Tomorrow? Okay.
Maybe just another comment. I think I've seen some research showing that as you age, your pure tone average decrease pretty linearly, or the hearing loss increase pretty linearly with age. But if you look at the signal to noise ratio that you need to understand speech properly, it has a different curve, which is more like exponentially at a later stage. So adding the signal to noise ratio capability, I think, is a highly relevant measure that should be used a lot more, because it does also give you better opportunities to tell people what to expect and what accessories. If you have a 15 dB signal to noise ratio deficiency, no hearing aid is going to make you hear well in noisy surrounding. It's not going to happen because you can't pick it up. Whereas microphone systems that you can place where the sound is coming from is going to help you much. And you would rather have to confront people with that fact early on than having them being severely disappointed and come back and want people give back for credit and all that. I think the whole counseling part and what to recommend people would be much more sort of easy to deal with if you had some of that evidence at hand.
So the takeaway might be the pure tone audiogram is not the only thing we're going to measure when maybe we're on our way to a clinical practice guideline here, right? I want to know any more questions. I think we have time for one more or another comment from anyone. Okay, well then, I'd like to thank the panelists very much for a great set of presentations. I'd like to also announce to you that we're going to have a break now, but we need you in your seats at 3:30 sharp. Okay? 3:30, we're going to start at 3:30 because we're giving you 5 minutes extra on the break. Thank you.